Hi everyone. So one of the things that I do every week is I always try to keep up with, what is the latest research, what's new, what's coming out. And one of the ways that I do that is every week I receive and read the Journal of Clinical Oncology. This is the journal from the American Society of Clinical Oncology. And I really like getting the print version. I like to go through and see what's published. And also, even though I only treat breast and GYN cancer, this kind of allows me to sort of keep up to date with, what are the big studies or what's new in some of the other cancer types. So let's read this one together. So in this journal, we've got an article on management of cancer during pregnancy. I have some stuff about multiple myeloma. I'm gonna skip over that one for now. And then talking about Carboplatin for early stage triple negative breast cancer and for recurrent low-grade serous ovarian cancer, which is a rare ovarian cancer type, looking at the combination of Ribociclib, a CDK4/6 inhibitor, that's Kisqali, plus Letrozole. And I'm actually a co-author on the Ribociclib plus Letrozole trial. So I'm excited to see that in print. Okay, so we're gonna go through, and the first thing I wanna highlight is the new guideline on management of cancer during pregnancy. And this is a really important guideline because there's a lot of nuance and complexity in treating a patient who has been diagnosed with cancer during pregnancy. And it varies too, depending on a number of factors: the tumor type, the stage, what can we safely do in pregnancy, and what can we not safely do in pregnancy. So for example, in breast cancer, there are certain drugs that we cannot give during pregnancy, like endocrine therapy or HER2-based therapy, right? So we have to think about how we're going to approach it. Is surgery safe? Do we need to postpone surgery? Can we give systemic therapy, right? These are all the questions that really factor into every cancer type. But what we know is staying as close to the standard of care is going to give us the best clinical outcome. So we really have to think about that. The other part that's really, really important is that we need a multidisciplinary team. No one should be taking care of these patients alone. So we need to be working with our oncologists, of course, obstetricians, radiologists, neonatologists, maternal fetal medicine specialists, primary care, right? Everyone should be involved in the care of the patient, starting with what is safe to do for a diagnostic workup all the way through, oncologic management and diagnosis. And this guideline goes through every treatment type, surgery, radiation, like what's safe, what's not safe. So if you have questions about what we can do during cancer and pregnancy, let me know and I'll try to answer them. Okay. The next study to highlight is looking at adjuvant post-surgery carboplatin for triple negative breast cancer. Now for triple negative breast cancer, we really do a lot of neoadjuvant therapy before surgery, and we add immunotherapy to chemo for stage 2 and 3 triple negative breast cancer. But some patients do receive chemotherapy after surgery. Some smaller tumors, or sometimes it just happens that it has to be given after surgery. There's all sorts of situations. And so we then often give ACT or ECT, A&E are anthracycline chemos. And this looks at, what is the benefit to adding carboplatin to that regimen? And in this particular case, it showed that adding carboplatin does improve outcomes. So in this particular study, so always something important to keep in mind as we think about what treatments we're going to give and when. And then the last study to highlight is going to be the low-grade serous ovarian cancer trial. So low-grade serous ovarian cancer, what you need to know about this cancer is that it's rare, and it's really hormonally driven, and it tends to be resistant to chemotherapy. And so when patients recur, we typically like to think about, can we give hormonal options? Now, actually, this past year, we had a specific targeted therapy approved for low-grade serous, which was really an amazing progress. So a lot of times we were giving Letrozole, which is an aromatase inhibitor, and this study looked at the benefit of adding a CDK4/6 inhibitor, Kisqali, to the study. And it was a small study, about 50 patients, but it showed, and everyone got the same regimen, Ribociclib and Letrozole. And what they showed was that there were meaningful response rates and durable disease control. So this certainly may be a treatment option for our patients. All right, lots of information here, but I think it's helpful to go through so you guys can see kind of what is the research that is being published and to talk about it a little bit. If you like this and want me to keep doing it, I'm happy to kind of come on weekly and tell you what I'm reading about. But let me know any questions about these studies and what you want to know.